This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Child's Nervous System titled Understanding Barriers to Pediatric Hydrocephalus Management, an international survey. It was published early in 2026 and provides a really sobering look at the global landscape of how we treat our youngest patients.
This is a crucial topic, Alara. We often talk about the technical nuances of a ventriculoperitoneal shunt versus an ETV, an endoscopic third ventriculostomy, but we sometimes forget that the best procedure is only the best if you actually have the tools to perform it. Hydrocephalus remains a fundamentally surgical disease. There aren't really any viable medical treatments currently available.
Exactly. And as the paper notes, the incidence is significantly higher in low and middle income countries, or LMICs, partly due to the high incidence of post-infectious hydrocephalus. The researchers, led by S. Edwin Ogiaco and colleagues, wanted to profile the neurosurgical perspective on these treatment barriers, stratified by the income level of the surgeon's country.
I think the methodology is quite robust for this type of qualitative look. They used an online survey that reached 45 neurosurgeons across 29 different countries.
Right. To give our listeners a breakdown of the demographics, the mean age of the respondents was about 49 years. About 64.4% were from high-income countries, HICs, and 35.6% were from LMICs. They looked at everything from surgical indications and preferences to specific barriers like equipment access and training.
Let's dive into the results, because the disparity between HICs and LMICs is quite striking, especially when we look at the most basic procedure, the VP shunt.
It really is. Even for VP shunt insertion, which we consider a bellwether procedure in pediatric neurosurgery, 81.3% of respondents from LMICs acknowledged barriers to treatment. Compare that to only 41.4% in high-income countries. The p-value there was 0.013, so it's statistically significant.
And if you look at why, it often comes down to hardware. The study found that 43.8% of LMIC surgeons reported hardware availability as a specific barrier for shunts, whereas only 10.3% of HIC surgeons face that issue. It's hard to imagine starting a list in the morning and not knowing if you have enough shunt kits in the cabinet.
It gets even more pronounced when we talk about endoscopy. ETV has gained so much traction lately, especially with the addition of choroid plexus cauterization, CPC, for infants or those with communicating hydrocephalus. But the barriers to ETV are massive in LMICs.
Give us the numbers on that.
So, 93.8% of LMIC surgeons reported a barrier to performing ETV. That is nearly every single respondent. In HICs, it was still about half, 51.7%, but the difference is stark. When you dig into the specific why, equipment access is the primary culprit, specifically the availability of the endoscope and the balloon catheter. 81.3% of LMIC respondents cited this as a barrier, compared to 34.5% in HICs.
That's a huge gap. And it's interesting because the paper mentions that surgical approach is nuanced. It's surgeon-dependent, patient-dependent, and resource-dependent. If you have a patient with obstructive hydrocephalus where an ETV is clearly the superior choice to avoid shunt dependency, but you don't have a working endoscope or the right Fogarty or balloon catheter, your hand is forced.
And what's heartbreaking in the data is the desire to do more. The survey found that 81.3% of LMIC respondents expressed a desire to treat more patients endoscopically. In HICs, that number was significantly lower at 44.8%. It suggests that surgeons and LMICs see the value of ETV, perhaps to avoid the long-term complications of shunts in regions where follow-up is difficult, but they just can't get the equipment.
I noticed the study also touched on barriers that didn't show a significant difference between the two groups. Things like surgeon and staff training, patient financial insecurity, and operating room access.
Correct. While those were reported as problems, they didn't reach statistical significance in terms of a difference between HICs and LMICs in this specific cohort. It seems that while training is always an ongoing need, the physical stuff, the hardware and the scopes, is the true bottleneck.
It's also worth mentioning the safety perception. Historically, the VP shunt was seen as the safer early option because of the likelihood of a successful early outcome, but as ETV has been proven safe and efficacious in landmark studies, the philosophy is shifting. Yet, as this paper points out, the shift in philosophy doesn't matter if the supply chain doesn't follow.
The authors actually hypothesized that medical indigency would be a major factor, and while it's a concern, the data really pointed toward the improper access to endoscopic equipment as the most frequent barrier.
So, looking at the big picture for our residents and fellows listening, what are the takeaways here? If you're practicing in a high-income setting, it's easy to take for granted that the shunt you want is on the shelf. But on a global scale, pediatric hydrocephalus management is deeply unequal.
Exactly. The conclusion of the paper is quite clear. LMICs face more perceived barriers across the board, but especially in endoscopic treatment. The author suggests that we need to focus on leveraging neurosurgical collaborations to improve care. It's not just about flying in to do surgeries, it's about sustainable access to hardware and maintenance of equipment.
It's a call to action. We have the technology to treat these children effectively and reduce the burden of shunt revision, but we haven't solved the distribution problem. The paper really highlights that the standard of care is currently dictated by geography and economy rather than just clinical indication.
It's a sobering reminder. For those interested in the full dataset, including the breakdown of the Likert scale questions on surgeon preferences, I highly recommend checking out the full article in Child's Nervous System.
Well, Alara, thank you for breaking that down. It's an important study that I think every neurosurgery resident should read to understand the global context of our field.
I agree. Thanks for having me, Dr. Aris.
And thank you all for listening to the Neurosurgery Hub podcast. We'll see you in the next episode.